Hi, everyone. Good morning. My name is Felix Gonzalez. I'm one of the MSK attendings at Emory University. We have a pleasure and honor to have today Adam Zoga from Jefferson. He's here to speak to us about core injuries. Adam is a colleague and one of my mentors when I did my fellowship at Jefferson, someone dearly admired by me and many others. Well respected in the community, in the MSK community. Adam has authored and co-authored more than 100 manuscripts and textbooks. He wears multiple hats at Jefferson. He is the vice chair of radiology, and he has been actively with a very active president at Vincera Institute. If you don't know that place, you can research it on your own. It's a very unique place to treat athletes with core injuries. He's the medical imaging director there. Adam has influenced the life of many, many, many fellows throughout the years. It's a truly honor to have him here today, a treat for us. There's a few things on the side. So this webinar series is meant for educational purposes only. Or interactive features for attendees have been disabled to ensure optimal quality for all viewers. Please email questions to Emory MSK Radiology altogether at gmail.com. If time permits, these questions may be addressed at the end of the talk. Announcements will be made as to whether we will record or post a video in accordance with the speaker preference. In this case, the video will be recorded. Attendees, they do not have any permission to screen record any of these talks, which may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. This webinar series is brought to you by the MSK Imaging Division at Emory University. So now you can take over, Adam.
All right, my title slide come up okay?
Yes.
Great. Thanks, Felix. So Emory MSK Radiology at gmail.com. Remember that or write it down. I'll be happy to answer all questions sent in afterward. I'm not sure I'll have good answers for all of them, but I'll give it a try. And so I'm sure you guys have heard this saying that is attributed to multiple people. Never let a good crisis go to waste. But this is a great job of innovation by Adam and the group at Emory MSK, taking a situation where we can't have on-site lectures and creating this this really strong digital lecture program for musculoskeletal. Thanks to you guys. Thanks for inviting me, and certainly thank you for allowing our trainees at Jefferson to join in, and really everyone nationwide who can see. I consider the Emory group a sister or brother program to Jefferson. We have a lot of great relationships with the strong MSK team, Monica, Walt, Felix, Adam, Phil, Scott, Paul, everybody. Thanks so much for your collegiality, and thanks for inviting me. So with that, I got involved in imaging the injury that was called sports hernia. And if you could see me on video, I'd have my fingers up with quotes right now, like Austin Powers, sports hernia. In the middle part of the 2000s. And it's been a journey since then, learning the pathophysiology, learning the nuances, some treatments, and really how to diagnose these injuries. The name sports hernia is passé. It's probably not a good name to use, and I'll explain why. But we're going to talk about the set of injuries to the musculoskeletal core that used to be called the sports hernia. So what is the core? And this definition is loose, without question. Put simply, the musculoskeletal core can really be anything in the musculoskeletal system, from the nipples to the knees, front and back. And that includes stuff around the pubic symphysis, that includes the low back, that includes the hip as well. It's all related. An injury to one structure often destabilizes biomechanics and leads to lesions elsewhere. So accept that the core is all related. And we published a book. Bill Myers did most of this book, and I was one of the consulting authors and provided some of the pictures and images and stuff. But this book is not really aimed at physicians. It's certainly not aimed at radiologists. It's more aimed at physical therapists, rehab folks, and guys who are going to diagnose and treat basic core injuries. But the concepts are really good. So gratuitous marketing here. If you have interest in picking up this book, it's a pretty easy read, and it's got some nice diagrams that folks might enjoy to help understand the core. I got to give credit to colleagues in the UK who started taking a look at imaging this fibroaponeurotic plate anterior to the pubic symphysis way back in 2007. This is about the same time I started to look at things, but they were really looking at kids, and they were doing high resolution imaging. I mean, that's a pretty good MR image from 2007. Phil Robinson and Andrew Granger, they've been sort of co-leaders in understanding what's now core muscle injury for the past 15 years or so. So I see this image and I start to understand how we got mature bone, immature fibroaponeurotic plate, muscle, and tendon all in the same location, as well as capsule. This is not copyrighted. This is we solicited some of the athletes who had core injuries to.
Adam, sorry to interrupt you. Your presentation seems not to be moving forward. We still see the first title page. Oh, there you go. Perfect.
Now you see the body world's bodies?
Yes.
I see. All right. Well, good. I got some extra time anyway. So my diagram of what is the core. This is from Von Hagen's Body World exhibit. He gave us permission to use this. And low back, hip. That's our book from Slack Publishing. And like I said, it's a basic background. So if you want to learn more about the biomechanics of the core and the PT part of it, this is a good place to read. And these are the slides from Granger and Phil Robinson's article back in AJR in 2007. They show this muscle, rectus abdominis, tendon, adductor, fibroaponeurotic plate, anterior to the pubic symphysis, and mature bone, all related to the midline core at the pubic symphysis. And we're going to talk a lot about that area.
I'm sorry to interrupt again. It seems like the slides are not moving forward, Adam. What we can see is the core slides.
All right, let me reshare. How about now? I'm moving. You see anything?
Yeah, perfect. Now we can see it. Yeah, perfect. I'm sorry about that.
Take 3. No, thank you for telling me. Tell me if it happens again. every time I say period, I have a new slide, so you can stop me. All right, so here's our book on the core. It was on the link that we Adam tweeted out as well. Here's Phil and Andrew's images. Now we're getting to Marshawn. This was funnier before I messed up the presentation, but Marshawn said to understand the core, you have to put on new eyes. The core is like family. To go forward, you must stay together. But he understands the idea that you injure one structure and the entire biomechanical axis is thrown off and you get lesions elsewhere. That's the whole point of the core. One thing's related to the other. So what is core muscle injury? So it's clinical athletic pubalgia. And I did a Google audit here of how many times sports hernia was searched for in Google. I'll show you in a second here how many. It's amazing. But it's a spectrum of disease associated with lower abdominal and groin injuries, and it's commonly referred to in media still as the sports hernia or the sportsman's hernia. It's not only in professional athletes or high-level athletes. It can impact anybody who's active. Weekend warriors are absolutely subject to core muscle injuries, athletic pubalgia. And in less than 0.2 seconds, I found 1.7 million searches for sports hernia just a couple of years ago. It's something people are interested in. So if people are interested in it, and it's a musculoskeletal injury, we ought to be interested in it, right? So I'm going to start with a case here. This is an American football player. He was a Division II quarterback, made it to the NFL, not as a quarterback, but more as a special teams guy. And he was interested in prolonging his NFL career as much as he could. He had an acute adductor strain on the right. So we see this, and what do we think? What do we think? Can you guys see my cursor okay?
Yes, we can. It's
Cool.
perfect.
So, you see this, and it looks like a big adductor longus avulsion type injury. Great, adductor longus avulsion, not a surgical lesion, maybe a grade 3 injury, retracted the myotendonous junction. But if you look a little closer, there's more than that. There is some edema in the rectus abdominis muscles, and there's productive change here at the pubic symphysis. If I get higher resolution imaging of the pubic symphysis region, I see productive change of the pubic symphysis almost like an arthritis. Here's our adductor longus avulsion injury, but I didn't perceive at the time the injury up here. Now I look sagittally. Now this is retrospective. I go back and I look at this a couple years later, and I see this abnormal signal in that region where we saw the fibroaponeurotic plate that Phil Robinson published, right? So this abnormal signal right here is the injury. And over the years, we've been looking for something to call this finding on the sagittal sequence where you see a breach of that fibroaponeurotic plate. I think my former fellow Jordan Gold called it the incipient breach, and we published it somewhere not in a very high impact journal. But that, whatever you want to call it, that lesion right there is sort of the start of a bad core muscle injury. And I'll tell you what happened. 12 months later, this guy rehabbed, got better, continued to play. And now he had a more nagging chronic adductor strain. Look, the arthritis at the pubic symphysis has gotten worse. Now it looks like there's sort of a secondary cleft on the right. There's edema in the right adductor longus. He was now diagnosed with an active core muscle injury, and he was offered surgery. He was concerned that if he had surgery, he would be released by the team and his career would be over. So he chose to rehab and not have surgery. And 3 weeks later, he's trying to block a punt in a game, and oh boy, this is what happens. So that's all hematoma. Now we've got a lot of badness going on, right? Everything has torn off, even exploded off of the pubic tubercle. There's nothing attaching anymore. He's got a major injury. This was the fibroaponeurotic plate. Here's the left, look at the right, it's just amputated. So a huge injury, and look at all the hematoma going into his inguinal canal. Well, at that point, his career was over. He did not play another game. And you wonder if maybe we would have been more aggressive with treatment before the big injury, he might still be playing. That same game, an offensive lineman gets an injury. And this guy comes out of the game, gets an MRI the next day, and it looks like nothing is attached to the pubic symphysis. It looks like everything is off at midline, extending to the left and to the right. Look at all the edema in the adductor longus. It looks like a terrible injury, right? This is a 280-pound guy, right? It looks like a terrible injury. We called it a midline pubic plate injury. We said it was a bad injury. I'm going across on the sagittals. Look at the hematoma bathing the lower rectus abdominis muscles. Well, he had surgery the next day after this MRI. And you know what happened? He was back in 6 weeks. And that was 5 years ago, and he has not missed a game since. So sometimes, I'm not saying surgery is always the answer, but sometimes aggressive treatment of these lesions can lead to better outcomes. And we have evidence-based literature to prove that, but it's just a couple of cases that sort of show my point there. So understand the central core muscle injury, the lesion that used to be known as sports hernia. This is a linebacker who only played one side of the field, and so he kept dropping into his hook zone. You know, that's sort of opening up to one side and dropping off toward the sideline in the secondary to cover an area of the passing game. And you can guess which side he would open up. He would open up to his right, rotating at the waist and hyperextending at the waist, putting all the stress on the right side of his core. And now he's got this big core muscle injury with look at the adductor longus, looks like it's amputated and retracted here. So that's a big right-sided core muscle injury. And this is just the best MR image of an active core muscle injury I could find. You see it in every anatomic plane. You see the rectus abdominis is abrupted from the pubic tubercle and pulled back. You see that the adductor longus is torn and retracted. And you see that the entire plate, the entire aponeurotic axis is pulled off of the pubic bone, destabilizing the pubic symphysis. So if you can remember this sort of this set of imaging findings, this pattern of imaging findings, that's the big active core muscle injury on one side. There's a cadaveric dissection that I did years ago with some of our fellows, and this was a very small cadaver, musculoskeletally small, right? But look at how thick the lower rectus abdominis is before it attaches to the pubic symphysis. It's a huge, thick structure, and this fibroaponeurotic plate is incredibly firm, incredibly thick, and undergoes just tremendous stresses and forces with activity. So that's our cadaveric representation of the central core, the rectus abdominis, the adductor longus, the pubic symphysis. They all play a role together. We dissected out that core, and I took it over to one of our scanners, and I scanned in the middle of the night. And I was a little nervous about doing this with the cadaveric specimen in the middle of the night, so I should have pulled the rectus abdominis up here toward where the head would be, but I didn't. It sort of flopped over. But I think you get the picture. Here's the rectus abdominis. Here's the adductor longus. Here's the pubic tubercle. This is where the action often starts, right here at this aponeurotic attachment to the pubic tubercle. This is, I think this one's a centimeter off midline, and this one's about 1.5 centimeters off midline. And about 1.5 centimeters off midline, you lose the edge of this aponeurosis, and that's where you get to the superficial inguinal ring. And that's sort of an interplay as to why it's called hernia. Some diagrams we solicited for publications on that same region of anatomy I just showed you, the rectus abdominis, the adductor longus. Here's the primary cleft of the pubic symphysis, and here's where the injury often occurs. Here's some low resolution microscope slides of the fibroaponeurotic plate, just showing all the cartilage and osseous structures, the cancellous bone, and then the fibrocartilage all in the same area. A very complex structure. We solicited these from an illustrator at Northwestern for our radiographics publication, and I think he nicely shows this beautiful rectus abdominis force of biomechanics, pulling the pubic symphysis cephalad, and then the adductor longus, not directly opposed, but orthogonally opposed, pulling the adductor longus inferolateral. So it's not a direct opposition, and that is one of the things that makes core injuries a little bit complicated from a biomechanical standpoint. Here it is in the sagittal plane, just our representation. This is where I feel like the incipient breach, the initial lesion occurs frequently. I did not advise the illustrator on the size of the prostate. I don't know what's going on over here. Might be a problem, but that's not a normal representation of prostate size. Now that we know what the central core muscle injury involves, let's look at a couple of really subtle imaging cases. So in this case, on the right here, here's the adductor longus in an axial plane on the left. Here's the superficial inguinal ring. And on the right, I said adductor longus, rectus abdominis, superficial inguinal ring. The rectus abdominis forms the posteromedial wall of the superficial inguinal ring. What happens on the right? Well, it's amputated. So it's a mild injury. It's right there at the posteromedial part of the superficial inguinal ring. So you can imagine if you did a hernia exam and you put your finger right through here, the patient's going to say, ouch. Here's a representation of the secondary cleft, or an inferolateral extension of edema on a coronal oblique image under the pubic tubercle. I have better pictures of that coming up. So look for these subtle findings for low-grade core muscle injuries. And then I've now moved more caudal toward the feet, and you see interstitial tearing. Confluent with the rectus abdominis tear, you see interstitial tearing of the adductor longus and more soft tissue edema. That's a lower grade core muscle injury, and there's a secondary cleft. And what we think really happens is this at the outset. We get a detachment of the fibroaponeurotic plate from the pubic tubercle. And once that happens, you're on the road to a bigger injury. Most of the time, it's lateral to midline. Most, not all. So we're trying to represent on MRI what we see here on these line drawings. Now that you've seen that, you can guess which side's normal and which side's abnormal here. It's a normal volunteer and somebody with a core muscle injury. See the core muscle injury here, the nice disruption of the fibroaponeurotic plate, in this case forming an interstitial tear right into the adductor longus. Right? Once we see one or two, they all sort of look the same. So that's the detachment of a low-grade core muscle injury, and that's what we want to be able to pick up at MRI. And there's our normal aponeurosis on the right side. So at this point, I hope you can respect that core muscle injury is a disruption of the rectus abdominis attachment to the pubic tubercle and the adductor origin on the anterior inferior aspect of the pubis. It likely reflects the injury known as sports hernia. That's a bad term, and we'll talk about why in a few minutes. It's most commonly an acute on chronic injury, but it can be degenerative tendinopathy as well. And rectus abdominis may predispose to an acute aponeurotic disruption. We've noted that some rectus abdominis injuries actually lead to the bigger injuries, as we saw in that first case, where it looked like it was an adductor longus avulsion, but really it was a rectus abdominis injury from the outset. The secondary cleft is an imaging finding. This is not a diagnosis. This is an imaging finding that I've got to acknowledge. Colleagues from Ireland, Steve Eustace's group, wrote 2 papers on this, and they injected a whole bunch of footballers, soccer players, if you will, into the primary cleft at the pubic symphysis, and they noted that the contrast they injected would go infralateral around 1 pubic tubercle, and in their papers, that correlated with the side of symptoms 100% of the time. I like the 100%, but that's what they published. And we adapted that to MRI. You can look for fluid signal on a fluid sensitive sequence, but this is actually a case where one of the NBA general managers did not believe in core muscle injuries. This is an NBA player. And he said, you got to show me a picture I can understand of his injury. So I injected the pubic symphysis just like I would with a therapeutic pubic injection. And I injected with a gadolinium-based contrast agent, took a T1 weighted image, and you can see the contrast going infralateral on the side of pain. Of course, you got a hip arthrogram too. That's why the hip is bright as well. So that's an arthrographic secondary cleft. So Bill Myers is a general surgeon, and he played soccer. He was a goalkeeper at Harvard. Afterward, he dabbled as a pro soccer player in South America. He pursued his surgery training and was the vice chair at Duke for a long, long time, and ultimately moved to Philadelphia to take over his chair of the now closed Hahnemann University Hospital, Drexel School of Medicine. He had a liver surgery grant there, but he brought with him his interest in these core muscle injuries, or these interest in groin injuries in athletes. And he moved away from traditional general surgery and started the Vincera Institute. The Vincera Institute it's a whole medical facility, rehab facility that's centered on diagnosing and treating core injuries. And he has an incredible amount of experience treating athletes with core injuries. He's published great outcomes, and I've been lucky enough to work with him since 2005. And he taught me a few things at the very beginning. One thing was that it's all related, that an injury to one part of the core leads to lesions elsewhere. And he said this was a study he did when he was at Duke, and this is a medical student he was working with. And he asked the medical student to put her finger under the adductor longus in a cadaveric specimen. He incised the lateral edge of the rectus abdominis, and the gnarly pubic tubercle sort of plopped down and pinched her finger and made her cry, according to him. That's his schematic here. But the idea is that when you injure the rectus abdominis, it destabilizes the pubic symphysis and causes the pubic tubercle to tilt down. And these biomechanical forces have to be accepted. There's all sorts of attachments around the pubic symphysis, and an injury to one leads to asymmetric forces on the other. And that's why this is often a vicious cycle of disease. Also, he incised the rectus abdominis with a manometer in the ipsilateral and contralateral hips, and there was a precipitous drop in pressure in the hip when you incise the rectus abdominis, even though they're not connected structures, which is sort of interesting, supporting the idea that even hip injury is related to traditional core injury. So to understand this anatomy at MRI, we've got to accept some of the anatomic nuances that exist in the pubic symphysis region. And this was really poorly published back in 2005. And, we've done some decent work getting the actual anatomy out there. The pubic symphysis is a joint. I mean, that's the one thing to accept. It's a joint. It's an amphiarthrodial joint, but it's a joint. And the pubic rami really serve to distribute forces all the way out to the innominate bones and to the hips. So the pubic symphysis is designed to provide stability. It shouldn't move much. So here's the the lateral border of the pubic bone, and then here's this pubic tubercle. The pubic tubercle, to me, is very analogous to the footprint attachment of the rotator cuff. It's gnarly. It's got jagged edges on the bone, and you can actually, if you rub a gloved finger over a cadaveric specimen pubic tubercle, it can actually tear the glove. It's really a sort of gnarly area of osseous anatomy, and that's where everything attaches. And there is a disc, but I think by the time most athletes come to imaging, the disc is destroyed. I think this disc goes early. We identify this disc in normal volunteers, but I rarely see the disc in athletes. And there's 4 ligaments. And to me, the key ligament is the arcuate ligament, or the anterior inferior pubic ligament. There's supposed to be other ligaments, but I can't pull them all out by MRI. It's very difficult, or by ultrasound. So here's the arcuate ligament, and it forms this big, thick aponeurotic plate over the rectus abdominis attachment and the adductor longus origin, as well as the disc. So this is the arcuate ligament, and to me, there's really 3 ways that this region gets injured. And once it's injured, I'm not sure it ever goes back to normal. The most common way is pregnancy, right? By the 2nd trimester of pregnancy, the arcuate ligament is sort of shot. Walking around pregnant is not particularly healthy for this ligament right here, and I think it's just part of the process. Now it can heal, but often women have chronic instability of the pubic symphysis after pregnancy, and that's even before childbirth. And 2 is falling from a height and landing on one leg as opposed to the other. Often that traumatically shears the disc in the ligament. And then 3 is what we see most commonly at MRI, and that's chronic overuse type symptoms with small lesions that destabilize the symphysis and lead to big lesions. There's a bunch of muscular attachments about the pubic symphysis that we have to accept, and that's the rectus abdominis. We talked about that, flexes the trunk, inserts all the way up on the xiphoid. From front to back, the pectineus is broad at its origin, almost like a platysma, but it becomes smaller at its insertion on the leg. It's not a very big muscle. The adductor longus is probably the biggest one. That's behind the pectineus, and that's got a big attachment to the pubic tubercle. The adductor brevis is just posterior to the adductor longus, small attachment. The adductor magnus is a big muscle, but less commonly involved in these core muscle injuries, more commonly involved in hamstring injuries. Sometimes the gracilis is involved, sometimes the obturator externus is involved, and we'll look at some examples of that. And then sometimes the accessory hip flexors are involved, the sartorius and iliopsoas. So we'll see some examples of all of these, but the key is that the rectus abdominis and adductor muscles oppose one another, and the postero-superior direction of force by the rectus abdominis on the pubic symphysis is countered by the antero-inferior force, anterolateral inferior force of the adductor muscles. So we got to acknowledge this biomechanical vector of force. And once we do that, we can start diagnosing these core muscle injuries. This is my dictation template for athletic pubalgia MRI, core muscle MRI. You can see, acknowledge the pubic symphysis and talk about the secondary cleft and things, then the midline pubic plate, then we go right, left, and then the more distal adductor muscles, and then don't forget the hips, right? The hips are related. So hip flexors, the hips themselves, and sometimes we get nerve impingement processes. I think this is a pretty good algorithm for trying to image core muscle injury. I always mention the inguinal canals, even though we rarely see hernias in this group, and you don't want to forget things like ischiofemoral impingement. So now let's look at a few injury patterns we saw in our first group. Our first study group was over 400 MRIs with variable protocol. I mean, extremely variable protocols. All these patients had been treated by Dr. Myers in one way or another, and we ultimately we excluded most of them, and we ended up with, I think, 142 subject patients. But we saw some recurrent patterns of disease, and one was injury at the pubic symphysis itself and arthritis at the pubic symphysis. And if you saw this at an AC joint, you'd say, wow, that's hot, right? Subchondral bone marrow edema, loads of bone marrow edema, a little bit of osseous productive change. That's an active arthritis, probably with instability. So osteitis pubis to me is an arthritis, but it can be both chronic with productive change or active with inflammation. And this one's active. Subchondral bone marrow edema spanning the joint anterior to posterior. That's osteitis pubis. Not my term. I know it's not a perfect term because it implies sort of an active thing and it can be a chronic thing, but yeah, that's what was out there, so we ran with it. So osteitis pubis itself often can be treated with therapeutic injections, steroid injections into the primary cleft often work for osteitis pubis. But the problem is, does osteitis pubis actually, is that a harbinger of a more extensive core muscle injury? And I think most of the time it is. Here's a 17-year-old. This guy's 17 years old. He was diagnosed with osteitis pubis and told to shut it down. He didn't shut it down. Look at his MRI. This is 17 years old. The ends of his pubic bones are resorbed, destroyed. I don't know what became of him, but osteitis pubis can take on a really aggressive pattern of imaging findings early on if activity continues through instability. And that's what's happened here. Here's a kickboxer. He liked to kick with one side more than the other, and I'll let you guess which side he kicked on. So we've moved away from the pubic symphysis, and what are these other patterns? So if this were your Achilles, what would you call it? Maybe hypertrophic tendinopathy, hypoxic tendinopathy, right? It's big, it's boggy, it looks degenerated. I didn't see much else at the core here, just this big, boggy adductor longus. So we can have isolated adductor syndromes. In this case, it was calcific tendinosis, calcific tendinopathy of the adductor longus. And we can have isolated adductor syndromes, and actually Dr. Myers has written a bunch on these isolated adductor syndromes before he knew me. And here's some of the things he wrote about. We'll talk about baseball pitcher hockey goalie syndrome and the adductor avulsion variant. But look for isolated adductor syndromes as a part of this spectrum of core muscle injury. This is a pro hockey player who only had symptoms after playing a period. So we imaged him, we didn't see anything. Then we had him play a period. He played a period and we immediately got him to the MRI and we imaged him again. And we had to do fast imaging as fast as we could, so the resolution's poor, but I think you get a picture of the pattern. The resolution's poor, but look at the pattern. The entire adductor compartment is swollen, enlarged, and even herniating a little bit through the fascia, right? So in a calf, if a muscle compartment is swollen, enlarged, and herniating through the fascia, it's compartment syndrome, right? So this is an adductor compartment syndrome, exercise-induced compartment syndrome. It's probably related to the fact that he's got these huge muscles and absolutely no subcutaneous fat. He's got no room for his muscles. But that's what he had here. So that's one adductor syndrome that we see occasionally. This guy I saw go up for a rebound, or went up for a rebound, came down forcefully, flexing at the waist, and immediately grabbed his groin. And it looks like just a terrible core muscle injury on the left side. On the sagittal and coronal oblique image. But then luckily we got a T1 weighted sequence where you can see the cortex of the bone. I love T1s on MRI. I think it's really helpful, especially if you don't have x-rays. And look at the avulsed pubic tubercle, off and torn and retracted distal. So I don't see that much, but that's another isolated adductor syndrome where you've avulsed off a piece of bone from the core attachment. So ultimately, our initial study that we published in Radiology in 2008, we had 151 subjects that we included, but we actually looked at well over 400 MRIs, and we learned much more than we were able to publish in the evidence-based paper. We decided that the vast majority of patients that came to Dr. Myers for this spectrum of disease had findings on MRI. Pubic bone marrow edema was huge. There were many, many confounders, including hip injury, and we should probably come up with a dedicated athletic pubalgia MR protocol. And so we did. We came up with an athletic pubalgia MR protocol in 2008. We've tweaked it numerous times over the years. I've published multiple incarnations of this thing over the years. And as receiver coil technology has improved, the athletic pubalgia studies have improved. But the basics are that I get 3 large field of view sequences of the entire pelvis. I start every hip and pelvis musculoskeletal study with these sequences, including non-contrast hip MRs, including hip arthrograms. Right, I start with a coronal coronal T1 of the whole pelvis and an axial T2 fat set of the whole pelvis, and then we go for the more high-resolution imaging of what we want to image. So then we get 3 sequences dedicated to the pubic symphysis, and if you have the coil technology where you can turn all the elements on for these first 3, turn all the elements on and then turn off the peripheral elements and leave the central elements on for the pubic symphysis, even better. You get nice imaging of the pubic symphysis structures. And I generally actually add another sequence and get another axial. We have 2 axial obliques and 1 sagittal oblique. Might get another sagittal oblique. You'll see a variety of these sequences. But high resolution small field of view of the pubic symphysis. There's one of the coils that has elements peripherally and centrally, and we can turn them all on for the large field of view sequences and then turn some off for the central small field of view sequences. Imran Omar, who's now at Northwestern, was one of my fellows when we were studying this, and he came up with the idea. He's like, hey, why don't we try to tease out all the adductors anatomically with an oblique sequence? And this is our axial oblique plane, sometimes coronal oblique, depends, you can call it whichever. The idea is you prescribe it along the arcuate line of the anterior iliac wing, and you take that through the pubic symphysis. And when you do that, you get an image like this. There's a nice volunteer with the fibroaponeurotic plate. Now we're going into the adductors, and we have the pectineus, the adductor longus, the adductor brevis, and the gracilis nicely unfolded in a normal patient. In this patient, you can actually see the disc. And now we have a hockey player with an injury. You see the secondary cleft. You see the edema, the interstitial degeneration going into the adductor longus. So that's our axial oblique imaging plane. And I think that's sort of become standard of care. It's really easy to do. You don't need anything fancy to get imaging of the pubic region and core muscle injury. Just a recommendation here. One of the things I think we do, I think we do a bad job as musculoskeletal imagers, is choosing protocols for pelvis and hip imaging. I think the non-contrast MSK pelvis protocol offers a lot of value in many, many patients. Once a patient has arthritis at the hip, I don't understand why you would do high resolution imaging of the hip. I think just a non-contrast bony pelvis gives you all the answers you need. It diagnoses AVN, it diagnoses hip effusions, it diagnoses infection, fracture, MET. I think it's really valuable. Gross core injury gets diagnosed. So I try to prevent older folks with arthritis from going through the 50-minute non-contrast high-resolution hip protocol and stick with just the bony pelvis that has those 3 sequences of the whole pelvis, and then maybe a sagittal directed to the area of concern. Here's our non-contrast hip protocol, just as a as a comparison point. We start with those same 3 sequences, and then we do 3 high-resolution sequences of the hip in question. And that's great for younger patients or patients where we're worried about labrum tears and cartilage loss. So imaging the core. Now that we know what the core is, right, let's think about imaging it. And let's think about imaging away from the pubic symphysis. We've seen pubic symphysis lesions, but what about all the other injuries? So we want to image this whole area, including the lower thorax, pelvis, lumbar spine, proximal thighs, but we can't image them all at once, right? We have to tailor our imaging to the area of injury. And in this case, this is a MAFO boot. And when I was starting out in musculoskeletal, people who had fractures would get this molded ankle and foot orthotic, and it really did a good job. Now everybody just goes and gets the generic boots from whatever pharmacy is close by, and then they get stress injury because the boot doesn't fit. That's a whole nother story. I like to think of the MAFO boot when I tailor my imaging to core muscle injury. Am I after myotendinous injuries, avulsive injuries, friction injuries, or osseous injury, and what body part? So you can start with this basic protocol that we use for a bony pelvis, and you can apply it to the lower abdomen, you can apply it to the upper thighs, you can apply it anywhere. So without question, when you're imaging the core, MRI is the modality of choice because it gives you the large field of view and diagnoses both soft tissue and osseous injury. You can get smaller, high resolution images, and you can adapt the musculoskeletal pelvis protocol to any region, really. And we use ultrasound, we use it a lot, but we use it to target therapy, and we use it to diagnose dynamic lesions. So here's just a body part. Well, what if you have an injury right around the iliac crest? So apply the musculoskeletal pelvis protocol, but place it here. What if it's in the slipping rib, a rower's rib, or a abdominal oblique injury? Same protocol, but apply it up here. What if you have thigh splints, stress fractures, hamstring tear? Same protocol, apply it here. You can really use that protocol for everything. Here's the questionnaire that I have patients fill out. I mean, we've been waiting so many years for the virtual waiting room idea. Now, because of the pandemic, we've actually got approval to run with the virtual waiting room. So these patients get this sent to their phone, and they can fill it out on their phone and put X's where they want to put X's, and type in all the entry here, and then send it back to us before they ever come into our facility. Finally, but I think it's a useful questionnaire, and I rely as much on this as I rely on the ordering clinician's order, because I think patients sort of know what their symptoms are more than anything else. So now that we know how to image this thing, let's look at some specifics of core muscle injury. This is an old study, but this is the one that I think won over my colleagues at Society of Skeletal Radiology. When I presented this, I think that I was given best paper, which was really a great honor, but it made people understand the pathophysiology of these core injuries. This guy was in his 30s, and he had been treated for osteitis pubis a few times with injections, and then he fielded a bunt. And if you could see me right now, I'd be bending over like a catcher and then wheeling to throw to first, right? Rotating and wheeling to throw to first as hard as I can. So we get the large field of view sequences, and here's a big secondary cleft, and also the adductor longus looks amputated and sort of pulled back, right? So we know it's a big right-sided injury. Higher resolution axial sequence. Here's the medial head rectus abdominis, lateral head rectus abdominis, and superficial inguinal ring on the left, normal. Look on the right, medial head's edematous, lateral head is missing, superficial inguinal ring is artificially enlarged. So imagine what happens, you put your finger right there, right? So there's the breach of the adductor longus, breach of the rectus abdominis, enlarging the superficial inguinal ring. Then we get into the adductors, and you see the adductor longus is sort of avulsed and pulled backward with edema going into both the adductor longus and the adductor brevis. But this is the best. Look at the sagittal imaging. All right, midline. Right, left. You can guess which one's right and which one's left. Look at the elongated tenoperiosteal disruption of this actively injured core. And look at the edema in the lower rectus abdominis. You can see the relation between the fibroacroneurotic structures, the muscles, the tendons, and the bone. That's an active core muscle injury, and I think it's a really good case to delineate what happens. Over the years, we've learned some nuances, and boy, nobody gets core injuries worse in my experience than rodeo cowboys. And they are forcefully extending at the waist and rotating, and their core takes the brunt of it. So this is a rodeo cowboy, and it looks almost like the adductor longus, adductor brevis, and pectineus are avulsed and pulled off together. They're retracted a few centimeters. Amputated from here, avulsed and retracted. Well, if you look here, we sort of lose the cortex just a little bit right here. So when the surgeon went in on this one, he was able to pull the stump back up and just tack back the periosteum. And this became a recurrent finding in traumatic injuries with extreme extension at the waist, like rodeo cowboys. And these are easier to fix than some of the other injuries we've seen. And since they're easier to fix and you can just pull back the periosteum, we thought they needed a name. One of our fellows, I'll give Andrew Palish credit for this, called it the anterior adductor avulsion lesion. We published the anterior adductor avulsion lesion. This is absolutely a surgical indication because they do really well. They get better quickly once the periosteum is pulled back. So that's sort of an avulsion of all the adductors together, anterior adductor avulsion injury. We noticed in 2009 that a subset of patients really had confluent bilateral injuries. So here's a soccer goalie. Look at this, where's the secondary cleft? It's not, it's sort of a pencil thin mustache type single cleft going from left to right. There's bone marrow edema on the right, and on the left, it goes into the adductor longus. That looks like a midline injury to me. And we felt like we started to need to call these things midline injuries. So in this case, I'd call this a midline pubic plate lesion, but on the right, there's bone marrow edema at the pubic tubercle. On the left, it goes into the adductor longus. And usually the symptoms are more common on the side with the bone marrow edema. So midline pubic plate lesion is another variant. It's not as common as the unilateral lesion, but it's out there, and you should probably diagnose it because treating only the symptomatic side can lead to contralateral injury. And we've shown that, and I think I have a reference for that in a minute. So midline pubic plate lesion is a continuous secondary cleft. At surgery, the periosteum is often dislodged along with the rectus abdominis and the symphysis capsule. I feel like, I haven't been able to prove this yet, but I feel like the midline pubic plate lesions are more common in females relatively. Overall, only about 28% of our core muscle patients are females. I'm not exactly sure why. I can talk about that for hours. But when I take those patients, more of them have midline injuries than the cohort of males. So I think it's more common in females. And if you're going to treat one side with these midline lesions, you probably should treat the other side. This is an unbelievable case. This guy, a minor league hockey player, he goes down into the butterfly position, has an acute injury. And look at this, he's got a big effusion at the pubic symphysis, right? Looks like everything's widened, big effusion at the pubic symphysis. He's got bone marrow edema on both sides, and look at the hematoma going into the pelvis. All right, so this is the bladder. This is not the bladder. So to me, this is a traumatic orthopedic disruption of the pubic symphysis. Sometimes this happens. Usually it's fall from height. This one wasn't fall from height. This was hyperabduction of the legs in a hockey player. Look at that big hematoma. So I'm trying to explain to the general surgeon who's treating this guy that this is an orthopedic injury with disruption of pubic symphysis. The general surgeon did not want to hear that. He said, it's just a core injury. I'm just going to treat it with mesh. But I don't think that's going to work. This is an orthopedic injury. He's like, you got to prove it to me. So this is a nice little quiver to have in your armamentarium, a nice little arrow to have in your quiver, sorry. There's a standing AP radiograph of the pelvis, and we do flamingo views where we have the patient hold his left ankle behind with his left hand, take an image, look where the superior brim of the right pubic bone is. Then we do the same on the right side, and look where the brim is. Now it's gone low. So we've proven instability at the pubic symphysis with radiographs. It's a dynamic set of radiographs, and it can be occasionally useful. In this case, I convinced the surgeon that he needed orthopedics consultation, and they actually went in and they stabilized the pubic symphysis along with fixing the core muscle injury. So when it comes to post-op, this is a tight end 7 weeks after a core muscle repair. Now, the core muscle repair seemed to be doing well, but he's got pain in his thigh. Why does he have pain in his thigh? Look how, this is way down here. And we see this a lot, a myotendinous junction strain at the adductor longus after core muscle surgery. Maybe the core muscle surgery tightens things up and they overdo it, and they get scar breakdown and fibrosis and stuff at the myotendinous junction. But often it's tough to get these things to heal, and they tend to do really well with injections. So they needed a name. Bill Myers called them baseball pitcher hockey goalie syndrome, these myotendinous junction strains that don't heal after surgery. I have not seen it in a baseball pitcher or a hockey goalie, which is sort of ironic or odd, but I see it in a lot of post-op patients. And maybe the epimysium of the adductor longus is torn here, and that's why it's tough to heal, but they do really well with the needle tenotomy or needling of the musculotendinous junction with ultrasound guidance. Here's another post-op consideration. So this guy had a history of right-sided pelvic floor repair. Now he has a left-sided injury. But when I go back and look, his initial injury was actually at midline. He was just symptomatic on the right. So now he's got a new injury. The right side is repaired, but he's got a new injury on the left with a secondary cleft to the adductor longus, right? Sort of a classic left-sided injury. I think this was not optimally treated because he had a midline plate lesion. Only the right side was treated, and now he has a left-sided injury. This happens. 4% of patients who had unilateral pelvic floor repairs came back for contralateral injury within 4 years. So watch out for midline lesions, and you won't have this scenario with people coming back and getting contralateral injuries. So something to keep in mind with the post-op patients. So post-op pubalgia considerations. I don't do contrast. If you're worried about infection, you consider contrast. Try to distinguish granulation tissue from the secondary cleft. I really try to get these guys on the best imaging systems, not necessarily 3T, but the best coils. Look for more distal adductor muscle strains, the baseball pitcher hockey goalie syndrome. Look for mesh on a non-fat suppressed sequence. I can show you some mesh in a minute, and then watch for confounding causes of groin pain. Those are just some considerations in post-op. So now we've got why is this thing called the sports hernia? So this is a pro football tight end playing at the Pro Bowl, right? Playing at the Pro Bowl. He has what we call a midline plate lesion, right? The lesion extends bilaterally. He gets diagnosed appropriately. He gets treated appropriately. He does well. And his coach says, you know, doc, I think I have the same thing as him. I think I have a sports hernia. So we get the coach on the MRI. Here's the localizer sequences, right? This is not the kind of patient who gets core muscle injuries, right? His core hasn't been exercised in many, many years, all right? We got to be reasonable when we're making these diagnoses, and let's look for common things, right? This is an obese guy, sedentary, not athletic, and he's got groin pain. So it's probably going to be a hip lesion, and it was a hip lesion, all right? So while it doesn't have to be a high-level athlete that has core muscle injury, we should probably target people who are at least active. And if it's not an active patient, look for other sources of groin pain, often the hip. Why is it called sports hernia? It was initially published a series of 18 patients treated with mesh herniorrhaphy with a non-palpable, non-visible hernia. And I think a lot of them had this. Look at the normal left rectus abdominis forming the posteromedial border of the superficial inguinal ring. Look how it's amputated on the right. You put your finger there and you do a hernia examination. Often patients drop to one knee in pain. I've done it. It really works. It's because of this musculoskeletal injury leaving a patulous superficial inguinal ring that sometimes gets better with mesh that this term sports hernia was started. And it's not a good term. It came from the surgical literature as a non-palpable, non-visible hernia, but it's really suboptimal because it leads to inappropriate surgeries. You got to address the musculoskeletal injury and not just the patulous inguinal ring. There are no true hernias on these guys. It's just a patulous inguinal ring. Sometimes mesh does help, but a lot of times it doesn't. And the reason we don't like sports hernia, this guy was diagnosed with a sports hernia and he was treated with mesh. You can see he was a baseball player. He was a slugger. He had groin pain. Treated with mesh. Here's the upper edge of the mesh. Here's the lower edge of the mesh, right? That's not where the injury is. He takes 8 months off, comes back, swings a bat, immediately has left-sided pain. Look at his left adductor longus. It's shredded. Look at his left core. There's the injury right there, right through the fibroaponeurotic plate into the adductor longus. He was treated with a mesh hernia repair. It was unsuccessful. He missed more time. It was just suboptimal treatment for an inappropriately termed injury. That's why I don't like sports hernia. Can we predict injury patterns? Now we're getting to some more, some later stuff. So different athletes do different things, right? Some athletes run in the middle of the field and move left as much as they move right. And I think it's tough to predict injury patterns in those athletes. Some athletes are more jumping. Some athletes, though, stay on one side of the field and they repeatedly open to one side. And these athletes are likely to get injured on that side. Some athletes stay on one side of the rink and open on one side, like wingers. Some athletes repeatedly do the same thing. Nobody more than baseball players does repetitive motion again and again that's asymmetric, unless you're a switch hitter. As they mature, they get more and more stress on the backside of hitters and the backside of pitchers. So can we predict core muscle injuries? We took on a project where we tried to do that, and this is still a work in progress, even though we presented the initial series way back 8 years ago. We had patients complete a thorough questionnaire on what they do, what side of the pitch or field they play on, and then we look at their injury pattern. And initially, what we found, we lumped all positions together, and we didn't come up with good statistically significant results. But then we looked at players who only played on one side of the field. And unilateral lesions were much more common in defensive players, defensive football players. The site is contralateral to the side of the playing field, 90% of the patients. Now we start looking at baseball players, and we see all pitchers injure the backside. Sluggers generally injure the front rectus abdominis and the back adductor longus. And now it's important because there are some commercially available products that can help treat these things. Here's the XL cord, which is designed to strengthen the backside in a pitcher. This is the Core X, which is designed to strengthen the core in whichever side you want, depending on how you position it. And so prevention is a part of PT for these athletes now. Now we use ultrasound to treat some of these lesions. And this is the orientation of the probe. You might want to, when you put the probe in this orientation, usually get a nice image of the core here with the inguinal canal, the adductor longus, adductor brevis, and the adductor magnus, and you can target injections to where we see the injuries. It's pretty simple. So I'm going to end with just a few examples of core injuries outside of the pubic symphysis. And I'm sorry I got a little late because of my failure to manage Zoom at the beginning. If I need to stop, I can stop. But I've just got about, I think, 6 or 7 cases outside of the pubic symphysis and how I approach them. So I try to remember MAFO, right? And I try to target the area that's injured. So this is a series of tennis players that all have the same injury, and we've got a bunch of them. We actually have them submitted to RSNA this year. I haven't heard back from them yet to see if it's in, but see the injury right here? It's in the mid-rectus abdominis muscle belly, right by the umbilicus. And this comes from serving, and it comes from the front side of servings because you're hyperextending and then forcefully coming down. She was at the US Open a couple of years ago. We treated her with an injection. It's a rectus abdominis tear or a high rectus abdominis injury. We injected her. She came back, got imaged again. She did pretty well, but that got imaged again because she lost. So that's sort of exclusive to tennis players. Watch that one and move your protocol high. Here's an NFL quarterback who was injured low core, right? So we moved this protocol down lower. And this was feared to be the dreaded sports hernia. But when I look, I find it way down here at the adductor magnus attachment to the thigh, right? So that's a distal adductor strain, a distal myotendinous adductor magnus strain. They do really, really well and they recover quickly. 2 weeks later, with just PT, he came back and threw 7 touchdown passes in a game. A couple years after that, he did something even better. But watch for those. This is an outfielder. This is like, I don't know if any of you are Braves fans, but if you watch the Braves hit all the home runs over the Phillies' head yesterday in 14 innings, this is what happens when the outfielders turn and run back toward the wall. This is our center fielder, turns and runs back toward the wall. And this is actually called outfielder's spine. And it's a strain of a particular muscle. We moved our protocol to the back, and that is the quadratus lumborum. And usually it happens running while rotated. So same protocol, but we just moved it to target the quadratus lumborum. Here's a pitcher with flank pain after throwing it. Same protocol. In this case, we took off the right half of the chest, but we injured the flank, and we see the myotendinous injury. You can make this diagnosis with the same protocol, just in a different location. In this case, it's the latissimus, sort of a grade 2 strain of the latissimus dorsi as it originates from the humerus. In this case, you got an arthrogram, but it didn't look like the injury had anything to do with the shoulder. And we get this same protocol, the MAFO protocol, but we move it up to the upper thorax. Only one muscle goes directly front to back in the upper shoulder girdle. That's the teres major. So the PT would be different, teres major versus latissimus dorsi. Here's a yoga enthusiast who has chronic sort of right-sided lower abdominal groin pain. Well, her problems are sartorius, very easily diagnosed with the same similar protocol. Grade 1 strain of the sartorius. You can get avulsions anywhere. I grade them just like I would anywhere else in the pelvis. Maybe a mild grade 1 is 25% or less on short axis of the myotendinous unit. Grade 2 is maybe 25 to 50, and then grade 3 is a more than 50% injury of the myotendinous unit on short axis. Here's an Olympic gymnast with acute debilitating right lateral groin pain after her tumbling routine. She was thought to have a sports hernia, but it's not a sports hernia. Look where the muscle edema is. The muscle edema is way up high. So we tailored the protocol. And then we used a sagittal to cover the myotendinous axis in the oblique plane. It's an iliacus muscle strain, easily diagnosed. Same protocol. There's a rugby player was thought to be a sports hernia, but really it's a rectus femoris muscle contusion. Muscle contusions look like strains, except you often get globular blood products intramuscular, and it makes the whole thing big. Really, I need history to be sure if it's a contusion, not a strain. This is one of my colleagues who overdid it on her new Peloton, and she's got more left-sided pain than right. Probably her cycling gait is not perfect, but she's got delayed onset muscle soreness, right? Muscle edema that enlarges muscle groups. It's just muscle soreness. It's just the post-exercise stuff that'll go away. Definitely happens more in your 50s than it does in your 20s. There's an NBA power forward who was diagnosed with a sports hernia and sent cross country to be imaged. But when we examined him, his injury was way below. So it's nothing at the pubic symphysis. It's an avulsion of the rectus femoris and retraction. We aspirated that fluid and allowed him to heal, and he was out for the rest of the playoffs, but he got better. So big avulsion from the anterior inferior iliac spine. Another avulsion, this time from the iliac crest. This is a quarterback who's got his internal oblique avulsed from the iliac crest. Another avulsive injury. The external oblique's a little injured. Iliac crest avulsion. In the sagittal plane, you see this nice hematoma. You can take out that hematoma and allow for the healing. Another avulsive type injury in the skeletally immature. So watch the skeletally immature avulsions. All you fellows, you should be making this diagnosis on the x-ray, right? That's the apophysis from the anterior inferior iliac spine. We shouldn't need the MRI, but the MRI often looks a lot worse. There's the apophysis pulled off in the sagittal plane, right? That's apophysitis at the anterior inferior iliac spine. Usually it's kicking athletes, skeletally immature. You got to give them time to heal and they'll get better. I don't know of any surgical intervention for that one. We did inject it under ultrasound, but we just sort of hammered it with a dry needle. And you got better eventually. These are all locations where you can get apophysitis at the pelvis. You get a lot of them. There's a grading system for apophysitis. I'm going to skip that. Here's some more apophyseal injuries. Ischial tuberosity apophysis injury in a 14-year-old male soccer enthusiast. Here's a 15-year-old female soccer enthusiast. Ischial tuberosity apophyseal injuries. So watch for the apophysis injuries. Know that they happen in classic locations. Ischial tuberosity, pubic tubercle, not the lesser trochanter, right? Shouldn't have the iliopsoas does not avulse from the lesser trochanter with normal bones, normal structures. If you see that, look for a tumor. In this case, there's a tumor. All right, so watch out for that one. There shouldn't be an avulsion of the iliopsoas from the lesser trochanter. Getting to the osseous part, right? So rower's rib, can we diagnose it? Sure, we can diagnose it. In this case, it's a strain of the lower latissimus dorsi. In this case, it's a slipping rib. We can do an ultrasound and we see that the costochondral junction slipping over itself. You can diagnose the rower's rib with the same protocol, the same MAFO protocol. Here's a baseball outfielder with nagging pain, right? So a friction syndrome in the ribs, right? Look for the scapulothoracic bursa. Look for any fluid collection down here, any myotendinous or osseous edema on MRI. There's the edema at MRI. Look at that. So once we see that, we can make a diagnosis of a friction syndrome, in this case, scapulothoracic bursitis, and we can target it with ultrasound and treat it and cure it. So watch for the scapulothoracic bursa. This is a very common, I see this frequently even in workman's comp folks. I see a little bit of edema right here, and we go right in with an ultrasound guided injection, and they're better within a few days. So that's an easy thing to fix. Scapulothoracic bursitis. There's a couple of bursae around the scapula, but really this is the one, the infraserratus scapulothoracic bursa. That's the one I see most frequently. Baseball slugger, I think I've got two more. There's a baseball slugger who has flank pain during his swing. So we moved our MAFO protocol up to the lower rib cage and we image him and oh, there it is. Easy to diagnose in this case. It's a fracture. He's given himself a rib fracture by swinging the bat. He was actually really proud that he did that, but needs time off to allow it to heal. And some smaller field of view, high resolution imaging, rib fracture from swinging a bat. And my last case, this guy. So this was presented at the NFL doctors meeting a few years ago, and it was presented by the team doc as a successful treatment for a sports hernia without intervention. Let me tell you what happened. He's a wide receiver who signs #1 wide receiver money. With his new team, he gets hurt in the first game. He injures both his groins. All right, here's the injury. He actually comes to Philadelphia and gets imaged. Team doc didn't know that. I have these images, and he's got a gruesome core muscle injury on both sides. I mean, really shredded on the right and not quite as bad on the left, but look at the chronic osteitis pubis. This has been brewing for a long time. Might have been diagnosed. You could probably diagnose it in the physical before signing him. So he has a bad core muscle injury on both sides. Not even really a midline injury. It's a right greater than left injury. He was treated conservatively. He missed 6 weeks. He came back, played a few games, but he never caught more than 2 passes in any game, even though he's getting #1 wide receiver money. They went to the playoffs, and in the first playoffs game, he caught no passes and they lost. So that was called successful treatment without intervention. I don't know about that. So wrapping up, MRI with the Pubalgia protocol is clearly is the standard of care imaging modality for imaging core muscle injury. I think as imagers, we should be familiar with things like osteitis pubis, isolated adductor syndromes, rectus abdominis, adductor aponeurosis pathology, or the core muscle injury that we talked about most of the day. True hernias are not common in this patient group, and the term sports hernia is misleading and can lead to the wrong surgeries, inappropriate treatments. The most common core muscle injury we see is at the junction of the rectus abdominis and adductor longus. The core muscle injuries away from the pubic symphysis are common, and they're really easy to image. You just slap your MAFO protocol on the site that needs to be imaged, and often you'll come up with a diagnosis. So, sorry for going long, but I hope you enjoyed it, and I'm happy to take questions.
Hi, Adam. This is Felix Gonzalez again. Thank you so much for the presentation. In all the cases that you went through, thank you so much for going over the anatomy and the pathology. We appreciate this information from an expert. We have a few questions that came through while we were presenting, and I tried to organize them in a logical manner. One of the questions is sometimes on the sagittal plane, when you're looking at the peroneal plate, the junction of the distal rectus abdominis and the adductor longus, sometimes the declaration of the MR information is not in a way of a true tear. You can see, sometimes you appreciate little areas of heterogeneity. How do you usually call that? Some of the options were interstitial degeneration, interstitial tearing, where you don't actually see an actual fluid like sin intensity to declare.
Yeah, I'm very familiar with that. And I generally, particularly if we're imaging because there's symptoms in that location, I generally say there's a low-grade chronic core muscle injury with soft tissue edema, but without active tear or high-grade disruption. And I hope that what that does is it leads that patient to an appropriate PT program, because PT can be very, very effective in those cases when you have a low-grade injury like that and things haven't pulled apart yet. So there is focused PT for the core that really helps. It's not just random PT. It should be a focused core injury protocol. And the other thing we might do with these low-grade, non-detached or non-disrupted tears, low-grade injuries is injection, ultrasound-guided injection, either dry needling or steroid. That's a debate for another time. Felix, you could probably lead that debate. But injections along with PT tend to help, and I just call them low-grade.
Perfect. Thank you so much. Another question is, there have been some literature published about the after injection on the ultrasound injection of PRP in that area of HO, heterotopic ossification. Are you a believer? Have you seen that in your practice?
That's a loaded question. My surgeon who treats most of these he's the one that sort of puts word out that says he thinks that PRP causes HO. I believe PRP is very useful in the right settings. I don't know if that causes the HO or if the HO is the initial injury and maybe the injection itself, regardless of what you're injecting, contributes to the HO. I believe in using PRP, particularly at entheses where the tendons attach to periosteum. I think PRP is really good. I think if you have a big muscle tear, mid-muscle belly, and you inject PRP, or you just stir up the blood products that are already there, you might contribute to some heterotopic ossification. But I have not seen it at an enthesis, and that's where I think PRP works the best.
Perfect. The other question is, I know we saw the protocol that you commonly use at Jefferson, and the first three initial sequences include the entire pelvis. The question is, how often do you see pathology that can be interpreted or can be followed as a pain generator that is not uniquely found in the pubic symphysis? So how often do you see labral tears and other injuries elsewhere, but the pubic symphysis that you guys follow clinically?
Yeah, so as you probably heard from Dr. Lamas's talk last week. By the time you're a certain age, almost everyone has a labrum tear, and it's hard for us to know which labrum tears are symptomatic. So I certainly comment on the hips in everyone. I comment on symmetry. You know, if there's just a little bit of chondral degeneration in both hips, I don't know what to make of that. I comment on detached labrum tears. I comment on joint effusions. And I comment on periarticular things like asymmetric gluteus medius pathology. We see all sorts of things on these large field of view pelvis sequences, and you know, I think you got to at least consider commenting on everything you see, but then try to be logical about whether it's likely or not likely to be symptomatic.
Perfect. You still have more time? I have a couple more questions.
Yeah, I'm good.
So the other question is, in older individuals, non-athletic patients, how are those people usually treated? Do they present with high-grade injuries, or do they commonly present with low-grade? And how do you guys treat those patients?
I do occasionally see high-grade injuries in older folks, usually lifting injuries, workman's comp lifting injuries. But more often than not, we see some chronic degeneration at the pubic symphysis, definitely more frequent in women than in men. And I think when you see chronic degeneration at the pubic symphysis, if you're older and you're symptomatic, boy, a steroid injection often does a lot of good. PT, again, is useful, but surgery is not very commonly performed in older patients.
And by older, you guys have a cutoff for age?
Yeah, my age plus 2. No, I don't. I really don't have a cutoff. But once we start seeing, you know, an obese 45-year-old is older at the pelvis than a healthy 55-year-old. So it's hard to make an age cutoff. Once I start to see osteoarthritis at the hips, I think of that as more likely a source of groin pain than anything at the groin itself, unless I see a real high-grade injury. But you know, the more you have low back issues and hip issues, the less you can even be mobile enough to cause core injury. So we start to move toward other sources of pain as we get into, I'd say, late 40s, 50s.
Okay. And one last question is, commonly, and we also go through this as well, sometimes referring physicians want us to image both the pubic symphysis and the hip at the same time. So we, you know, adding the extra sequences are definitely helpful, but sometimes we struggle letting the clinician know that hip, you know, the dedicated hip imaging is separate from or distinct from the pubic symphysis. Do you guys go through that a lot, or do you try to assess on your wider field of view? You're trying to look, and then if you see pathology, you pursue the hip with a dedicated hip MRI.
Yeah, this time of year, that's common. We used to go through it much more. Now, I feel like the new non-operative sports medicine folks, every year they try to push that on us. But what we do to combat it is we go out and lecture, a whole bunch of us, not just me. We try to go out and lecture where our referrers practice, so that they can see, you know, this is my livelihood too. I want to do optimal imaging of the hip, including an anesthetic exam if you think there's a hip lesion that could be fixed with arthroscopy. I want to do optimal imaging of the pubic symphysis with high resolution sequences if you think that there's a core injury that we could target. If you're really lost and it's a confusing patient and you're lost and you're going to refer me patients in the future and we're going to develop a relationship, then I'll do you a solid. All right, we'll do a bony pelvis study and we'll do a sequence or two of the hip and a sequence or two of the pubic symphysis. But that's not going to be my standard.
Great. Well, thank you so much, Adam Zoga. Oh, this is an honor, and we feel privileged to have you here. And thank you for giving up your time to educate us all. So with this, we culminate this sequence today, this presentation today.
Thanks for having me, guys.